Multi-specialty coordination breaks at the handoff. Communication failures show up in 80% of the serious medical errors that reach the patient. Chat LLM agents on a flat-to surface make things worse. One wrong call contaminates the whole answer, and the trail of which specialist was consulted is gone. Trusted Risk Care Engine moves the orchestration into the federation itself. One prompt, 16 subagents, 257 workflows, and every consultation is traceable. We will walk through 3 demos. We will use 2 patients today. Marcus Reyes, 63, with urosepsis from a complicated UTI. His chart ships a full SOAP document reference. Eleanor Green, 78, with heart failure, acute kidney injury, and a paroxysmal atrial fibrillation. Her chart has no document reference by design. Both threads bind to the orchestrator through the SHARP-on-NCP FHIR context. Marcus is septic. We ask for a complete sepsis pipeline. The orchestrator picks complete sepsis pipeline, a macro that runs 3 sub-workflows across 4 specialists. The chat response comes back as 4 headline blocks. Triage assigns ECI level 1 with an ICU disposition. NEOS 2 lands at 16 out of 20 with an emergency response recommendation and a per parameter breakdown. Antibiotic stewardship reads the urinary source and picks nitrofurantoin for the empiric round, with a de-escalation path to amoxicillin already prepared and an ID consult letter drafted. Transitional Care Management flags 7 care gaps and reconcile the medication list. Multiple specialists, 1 prompt, 1 structured answer. Same patient, different prompt. The orchestrator reads 2 capabilities out of 1 sentence, the discharge handoff arc and a prior authorization appeal letter. It runs them in parallel and the chat opens with a single-line completion banner. 2 trusted risk capabilities, both done. The discharge bundle reports 14.38% 30-day readmission with no fairness disparity across age, race, and insurance. Medication reconciliation adds tamsulosin, retires the antibiotic curse, and the discharge contract is satisfied. The disposition is home, with home health nursing, PCP in 7 days, urology in 4 weeks. 3 optional steps are reported as skipped: a caregiver handoff waiting on a clinician's decision card, and a patient FAQ waiting on a real question. The workflow completes. The gaps are named, not hidden. The PA appeal letter is drafted alongside, with no second prompt needed. We switch to Eleanor. Her chart is empty by design. We wiped every clinical resource, leaving only the patient resource. We send the same discharge prompt against her. The response opens with an explicit abstain warning. Each tool names the structural reason it could not score. Missing chart observation on the numeric tools. Missing clinician inputs on the scribe. Missing decision card action on the handoff. A regulator replaying this call sees a documented refusal with a reason recorded for every tool that abstained. The system commits when the data lets it and reports the gap when it does not. All of this is testable. We run 150 end-to-end cases against every workflow, every macro, and every specialist route. 124 pass and 26 abstain, with every abstain clinically legitimate and 0 crashes. All 50 macro care arcs pass. The Federation runs 16 specialists at 100% bundle coverage. It publishes an OpenAPI 3.1 spec, and its dispatcher has 2 layers: an LLM ranker on top with a deterministic keyword router below it. The orchestrator runs server-side, so every dispatch can be audited. Trusted Risk Care Engine. One prompt, 16 sub-agents, every consultation traceable.